Welcome Dr. Archana Sarda to NUCD 2022. We have
Thank you, sir.
Discussion that is everybody is discussing about mental health and adults, but nobody talks about mental health of children with type 1 diabetes. That's a very important issue though. In your large experience of handling children, mostly rural children, their parents, you must have seen a lot of them have many symptoms that indicates that they are not mentally stable. So what do you think type 1 children get mental health problems? What is your experience?
Thank you, sir. First of all, thank you so much for having this topic here, because this is not talked about much. And it is a vital topic, not only just because we are concerned about mental health, but because it also has a direct link with the outcomes of diabetes care. Because self-care suffers when mental health is not balanced, when it is not so good. So in type 1 diabetes, over the years, last 20 years, we have observed, other than the clinical action that we already know, that depression coexists, but the entire situation itself. First is the way the first consultation happens. I feel the most important is the first consultation. If the first doctor, the child and the family met, scared them and said, oh my God, this is dangerous, the life is in danger, you'll take so many injections, nothing can, your kidneys may go bad. This, unfortunately, people start on this kind of a treatment, and that has imprinted forever. It's very difficult to get that impression out, the first impression. So the first consultation has a very big impact on children and their family. Secondly, when it dawns upon them, it's every day. In DKA, when they're admitted for the first time, they're able to accept injections, they're able to accept all kinds of medical problems. But when they realize it's going to be forever, and that is the second time when it becomes very difficult for the family. And third is the day-to-day coping. And the whole family changes. It's not just the child, all the way from waking up to sleeping, to eating, to checking. So this whole magnanimity of what has happened affects the family so much that there is anger, there is denial, there is depression, there's inability to cope, there is frustration. So the entire grief process that we know happens, all stages are there. Sometimes people get stuck in a stage and not able to go forward, but it's an
right.
actual issue.
Absolutely correct. And at this stage, as we know, the children can be grouped into 0 to 5 years, say they don't speak anything. The mother has to understand their body language and understand what they are speaking. Then 5 to 10 years, then teenage comes, and post-teenage, the children when become adult and facing their life. These all stages have different manifestations. So sometimes the child is sad, loss of pleasure, and all those things. So how does a clinician spot that this child is going for something more, not only insulin adjustment, he needs more treatment or more adjustment or more therapy?
True, sir. That is very difficult, even though we have guidelines on how we can do it, but it's very difficult for a busy clinician in their clinic in a typical scenario to pick up mental health disorders. But some clues that a person would have, of course, first is the immediate behavior of a child, eye contact, lack of confidence. This is something we can study and learn. But most important is the history we get from the family. So for every child who we treat, it is very important that we talk to their siblings, we talk to their family, and we come to know whether it is the bodily functions, when it is sleep which is being hampered. So a child may throw tantrum in your clinic, may show that he's depressed, but he's going out with friends, he's sleeping well, he's eating well. So we know that it has not affected his bodily functions. He just doesn't want to check his sugar and creating a tantrum. So there is a difference. So there is a whole criteria. Another way of screening is we have many scales. For example, if we suspect depression, there is a scale called PHQ-9. So in fact, I once did a study in my children and I thought they were doing very well. But when we actually did the distress scale and we did the PHQ-9, it was a large number of young adults who were depressed. And this was, that is clinical depression, which I had missed out on. And that put me into action when we started screening everyone regularly. Sometimes we cannot detect it, just like that in our clinics. So suspicion is when their sleep is hampered, their work is hampered, their responses, their socialization, not wanting to meet anyone. But
In
picking up has
those,
to be clinical with a
in
distress state.
those scales, the whatever you are testing, what parameters do you test?
So these are standardized scales available for age groups, for social determinants, and various mental health issues. And they are available all over the. We can talk to a psychiatrist and get one which is suitable for our situation. These are very standardized analogs where you ask questions and the score is given, and the score gives you a kind of an indication and where are you in the scale of depression.
That's
And
great.
these are very good scales to use in our clinics.
Our pediatricians, our general doctors, our diabetologists, endocrinologists, they see childhood type 1 diabetes.
Right.
But when such a situation occurs that the child needs more than physical treatment or insulin treatment, whom should they contact, like counselor, therapist, psychiatrist, and social worker? And where are they available?
Right, sir. I think that's a very valid thing because it's very difficult to get them. And whenever a child we detect has psychosocial emotional issues, most important factor is not to let it go. It has to be addressed. It is as important as we manage their insulins, because of these issues, tomorrow they will stop taking insulin, or they will write fake diaries or give you some false feedback, and tomorrow you might get news that the child is dead. We think it's dead in bed syndrome, but it is actually a child who omitted insulin in the night or took a double dose and went into hypoglycemia. These are documented cases which have happened. So we have to reach out. Every team who works in type 1 diabetes should have a counselor. So most important person is a counselor. Usually counselors are clinical psychologists who are trained in young people, how to tackle to young people, to do motivational interviewing, to have interaction with them. Only when they have screened, talked, spent some time with them, they tell us that no, needs a psychiatrist. So the first step is not a psychiatrist unless you have a absolute clinical depression which you can diagnose. So most important is having a counselor. Of course, if we do not have a qualified counselor, we can train our staff. We can get them formally trained, but these are very special techniques. And it is important that somebody trained talks to them, because there's a lot of unsaid things that have to be picked up, a lot of things which have to be extracted. And so a counselor who is qualified is the best person. If we don't have one, every town nearby somewhere would have one. And it's important we have a few people on our list, take the appointment. Another point, sir, is we should first talk to the counselor to whom we are going to refer. Right. Because many of the counselors are not aware of the type 1 diabetes background. Suppose they are not into type 1 diabetes totally. So we have to first tell them the entire background, and we have to be in communication with them as well. So counselors are the first step. Psychiatrists are few times only it is needed after the counselor has seen them.
Like in USA, a lot of clinical counselors, particularly specializing in type 1 diabetes problems, are available. I think that group of therapists are needed in India. Absolutely. And absolutely some more work needs to be done.
Chronic disease, and that too in the growing age. I mean, that's a double trouble for a child, a chronic disorder at a growing age.
So in your large number of patients, how do you find this? What are the effects of depression and such mental health? Like do they school performance? Yes. And all those things. What is your experience?
Absolutely, sir. A child who is, it need not be depression directly, even simple things like not being able to adjust, or being in a denial mode, or being very aggressive, or even these simple things can hamper a lot of things. They can hamper their activity. It can hamper their dose adjustments. They will not like to monitor. So that is how they rebel. Some people will go on binge eating. Some people will refuse to eat. So everything ultimately also affects their growth. It affects their memory. It affects their concentration, their interactions with their peers as well as their family. So medically outcomes also, HbA1cs when we see with patients who are not able to cope, their psychosocial emotional well-being is just as important for them to be able to have a great HbA1c as well. In fact, one of the major reasons for not being able to achieve a perfect HbA1c is not the medical reason, but the psychosocial aspect, which they are not able to.
One of my experience, a young girl, I don't want to mention her name, from a well-to-do family, is a very good dancer and everything, type 1 diabetes. Once I started putting her on a 14-day CGM sensor, after that she has become depressed.
Very well.
What
Yes.
is my life? What
Right.
is my life? She is now repeatedly telling her mother that I am in trouble and I don't like that. Denial has come from her. So at this stage, how do we manage these children? What is the role of support groups?
Yes, sir. I think that is absolutely hitting the nail on the head. Before we go into psychiatric screening, counselors, psychiatrists, I think the first point program is the doctor who is treating, the educators and counselors that we have in our team, and the peer support group. Because this is where we can work at the first step itself. Any person comes with the thought, why me? Then they think of why only me? Then they say, what will happen to me? Then they worry about the complications if they study about that. But when they meet their peer group, if I meet 10 people of my age who are doing a great job, who are going to college, who are going to school, who are playing, who are dancing, and who are taking care, I immediately come to know it can be done. The doctor saying it doesn't work, but peer saying it really works. So what we do, for example, in Udan is if they can call somebody, we have helplines and we call them friends line. Like you have a helpline, we have a friends line. So this is a friends line where kids can call up somebody any time of the day. It is not for sugar. It is just to say, I'm feeling lonely. So we get calls saying that I don't feel like living. My mother has scolded me so much. I feel like taking an extra dose of insulin and dying. So it's, but just talking to that person, why? So if somebody receives your phone call, that itself can take care of people. It is so important that somebody cares, somebody doesn't judge, because a support group will not judge. So that is very, very important.
In our day-to-day clinical practice, who will be that somebody? You
The
have
best,
an organized setup,
yes.
so you could have so much of lines and all that for a single clinical
The
doctor.
best person to be a support group is a person with type 1 diabetes, or a mother or a father of child with type 1 diabetes who has done well in life. Somebody you feel is very emotionally balanced, wants to give back to society, or you could give them a small stipend. I give them a small honorarium for doing their work. They don't ask for it, but we give them, and that is motivational for them. So any person who has empathy, experiential learning is already there, and we can train them on some parts of it, and they become the best supporters for other people with type 1 diabetes.
Do you think the idea of connecting our children with type 1 diabetes among themselves on a Zoom call or over something like that, periodically, monthly once, and we be present there and discussing among themselves their problems for 1 hour, I think doctors should start doing that.
Yes, that can be done, sir, for any clinician. Maybe once in a month, they can have a group therapy. You can just put them in a circle, put up some topics, let everyone speak, and you can sneak away in between, because then they themselves will talk amongst themselves. Nothing works better than that. You can say 10 things, but what a peer group says works the best. But so there are also some downfalls. One has to be very cautious, because if even 2 children are very negative in that group, so our supervision that way is needed. In fact, negativity is easier to spread than positivity.
That is very
so
important.
There has to be a very subtle observation in these groups. There could be a child who is totally neglected. You might have smart kids there and one who is feeling low. At the end of the conversation, she may feel even worse about herself because everyone else looked smart. So the doctor who organizes a group therapy has to be very vigilant that these are like-minded people, and there's the observation, because it can have a detrimental effect also. So that observation should always be there. But Archana, it works beautifully.
Archana, I have in my practice of so many years, I have found in Odisha, which is a particularly poor state, many parents cannot provide or afford to provide even insulin to their children. And even if we give insulin, they cannot come from 200 kilometers, 300 kilometers. They do not have bus fare. So this is now being taken care of by government providing insulin at a PSC level, and many helping groups are coming. But at this stage, type 1 diabetes in poor setup, what are the mindset of parents? How do they face it? How do they manage it?
Sir, in a rural setup, if a family has 5 kids or 4 kids and a very meager earning, then to focus, and if somebody can provide insulin, they will take care of the child. But to focus on the well-being of a child from a psychosocial, emotional aspect is too much, because they have to work daily wages, they have another 4 kids to eat. So what actually works is because they feel this child is useless. There is a base in their mind that this child is a burden. Why do they want kids? I mean, it's a very blunt way of saying it, but still they want kids because they'll grow up and take care of themselves, of parents. They will earn, they'll get married and give them grandkids. This is what an average parent would say. And they feel their kid is not going to be able to do any of these. So what works in our rural families, because I work in the same area, is assuring them that this child is going to get married, this child is going to work, is going to be a productive member of your family. You will not have to take care of them forever. He will take care of you when he is older. So once they realize the child is just as normal as other siblings, their attitude changes. And that is something we have to really do step-by-step counseling of our parents. Also, we have to show them role models. You introduce them to other people who have become better. So I have children who have started as a barber's son, and today they have Javed Habib saloons in metro cities. So empowerment gives them energy.
Archana, we are almost out of time.
Yes, sir.
There are many physicians, clinicians are listening to us.
Right.
What is your message to them? What do you want to share particularly with our physicians as a message regarding psychosocial well-being of our type 1 diabetes patients?
Yes, sir. So my very, very strong message would be, when you meet a child and a family with type 1 diabetes, do not use the scare tactics. That is the first thing. Second, empathy is very important. A little less control of blood sugar can be rectified later, but an emotional mental breakdown can be harming them for the rest of their life. Third, if we do not have a system in place, please find an NGO, please find an organization in and around somewhere and reach out. If not, then there are many online support systems that can be reached out. But every child and every family undergoes a lot of emotional trauma. It's our duty to find a way to connect them to another support group.
Thank you, Archana. Dr. Archana Sarda was talking so many sensible things. This proves that in India, we need a lot of things to be done in this scope of type 1 diabetes, and a lot of new manpower to be created, and social awareness is to be created. Thank you. Thank you very much, Archana.
Thank you, sir.